All right, guys, how are you? Good morning. Thank you. Hang on one second. I want to pull this up for Paulina. Just had it up, and of course my fat finger deleted it. That's terrible. Anyway, so thank you so much. I'm so excited to introduce our Mason lecture. You know, there's a lot that goes into the program, and one of the big things is people want to know who are you going to invite, and I never had a doubt who I would invite. And I'm going to tell you a little background, and then afterwards, when you hear her whole talk, you'll know exactly why. Paulina Salminen is a professor of surgery and gastrointestinal surgery at the University of Turku in Finland, and she's also did her general surgery and digestive surgery training in 2005 and did her PhD in 2007. She's been working at Turku University Hospital with a clinical interest in metabolic and bariatric surgery and acute care surgery. She's been a full professor of surgery since 2019 and also is concurrently the chief of surgery academic position at Turku University Hospital. Paulina is past president of the Finnish Surgical Society, current president of the Finnish Society for the Metabolic and Bariatric Surgery, past president of both Finnish Digestive Surgeons and Finnish Society of Gastroenterology. She's currently the president-elect for the IFSO European Chapter. She's editor-in-chief of the Scandinavian Journal of Surgery. She's an editor at the British Journal of Surgery, member of the International Editorial Board for JAMA Surgery. She's been a member of the European Surgical Association since 2019. She was nominated as an Honorary Fellow of the American College of Surgeons in 2022 and an Honorary Fellow of the ASA, American Surgical Association, in 2024. She has over 200 peer-reviewed scientific publications, over 60 scientific book chapters, 4 edited textbooks. She has supervised 8 completed PhDs in her time, as well as currently she is supervising 14 PhDs. She's hardcore, I'm telling you. So she's also received over 4.7 million euros of external research funding. She's the PI of 7 multi-center randomized controlled trials. Her main research interests are in the fields of metabolic and bariatric surgery. She is the PI for the SLEEVEPASS trial, and also the SF Barry score and acute appendicitis, which created a little bit of a ruckus here in the US. She also did that randomized controls trial. The initial APAC trial comparing appendectomy with antibiotics for uncomplicated acute appendicitis was selected by JAMA editors as 1 in 10 articles of the decade in 2010 to 2019, and is the most important to clinical medicine and public health. So in addition to all of her accomplishments, if any of you know Paulina, you know her to be a kind and genuine person. She's straightforward. When she thinks you're full of it, she'll let you know with a beautiful smile on her face. I am honored to consider her a friend, and I want to welcome you to the 2024 Mason Lecture.
I would like to thank Dr. Marina Kurian for this very kind introduction, and I would really like to extend my thanks for this keynote lecture invitation, both to her as the ASMBS president and the chair of the scientific committee, Dr. Rachel Moore, and the ASMBS organizers. It is such an honor to be here on the stage today and speak in front of you all. The talk of my title is Trials and Tribulations of RCTs and Long-Term Follow-Up. The story of the SLEEVEPASS trial. These are my main disclosures with actually no real conflicts of interest for this talk. A clear relevance for this talk and its contents is, of course, my role as a PI of multiple randomized clinical trials, and here, of course, as the most important one is the SLEEVEPASS trial. My other main research field, as Marina told, is acute appendicitis with multiple RCTs called APAC, with Roman numerals after it because it's much easier that way, on non-operative treatment on uncomplicated acute appendicitis. Content-wise, the other relevant issue is my work within all of these listed surgical journals. This enthusiasm for RCTs underlines the fact that I'm a huge fan of evidence-based medicine and evidence-based surgery. My dream and belief of evidence-based surgery is reflected by my disclosure slide's current primary procedure pie chart. It used to be the other way around, but after receiving the follow-up results at long-term from our own RCT, the Roux-en-Y gastric bypass has taken over some space from sleeve gastrectomy over these past few years. I have to start by acknowledging the pioneering contributions of Dr. Edward Mason in the field of metabolic bariatric surgery and treatment of severe obesity in general. I am truly deeply honored by this amazing opportunity to present as this year's Mason Lecturer. I unfortunately never got to meet Dr. Mason in person. I have only read his science and watched the ASMBS IFSO video of the interview at his house in Iowa and his own Mason lecture recording from 2014. I do, however, coincidentally have a very close connection to Iowa, and the two pins in the picture are the city in Finland where I'm from, so Turku, and Iowa City for Dr. Mason. So in 1959, my mother was one of the first exchange students to come to the US to spend their senior year in high school here, so in the States. So she spent a year in Independence, Iowa, and ever since she has had a very close relationship and contact with her American family, and I ended up having an American godmother. My American mom and my godmother, Laurie Randall, is the younger daughter of the family that my mom stayed with, and I ended up spending my exchange student year with her in 87, 88. She's in the middle picture with the very 80s version of me. And on the left, I am with my American grandparents, Joe and Helen Randall, in Independence in Iowa in 87. I only have positive memories of spending time in Iowa, but I do have to confess that when I was coming over for my high school year, my American mom was just moving out of Houston, and she was contemplating between Iowa and then California. And as a 17-year-old Finnish girl, you can imagine that I was kind of praying that please say California. So I ended up graduating from Benicia High class of 88. The majority of the content of this talk is focused on underlining the importance of high-quality research and hopefully to motivate us all in this hard task of being a surgeon scientist. In the current era, with the obesity management medications, the OMMs, being a crucial part of the treatment of severe obesity and a new tool in our toolbox, with great synergy, and I'm hoping that at the end, OMMs will actually increase the access to treatment and improve the underutilization of metabolic bariatric surgery. However, I do think we have to step up our game of metabolic bariatric surgical research quality to comply with the very high quality pharma research. I will first go over the two challenges of conducting RCTs and then show you a few examples of the importance of being able to look at things from a different perspective. I will share the story of the SLEEVEPASS trial with you and all of the things I've learned along the way, which means all of the mistakes I've already done, and also the appreciation for the immense value of national and international collaboration. I will finish my talk by highlighting the need to have standardized uniform definitions and criteria, as otherwise we're just comparing apples and oranges, and we do not really have comparable data between different studies. I will show you our SF-Barry score as an aim to have a comparable composite outcome and some unpublished data on the validation with the large Nordic registries. And hopefully I will be able to encourage all of us to further contribute to the surgical science within our field. I will just shortly tell you where my enthusiasm for evidence-based medicine and RCTs started, as I think it's kind of relevant for the whole story. As Finland is a very small country, there are no surgeons that would be solely metabolic bariatric surgeons. My background is very much in the foregut and pancreatic surgery, and I did my PhD on the surgical treatment of gastroesophageal reflux disease under Dr. Jari Ovaska's supervision, who's on the picture on the right. And he was one of the pioneers of laparoscopy in Finland in the 90s and my mentor in laparoscopic surgery. The person in the middle is my first PhD student within metabolic bariatric surgery, Dr. Mika Helmiö, and one of my closest team members currently. My thesis included the long-term follow-up of Dr. Ovaska's RCT from 92 to 95. Comparing open and laparoscopic fundoplication. Conducting this long-term follow-up really helped me in realizing two important things in surgical science. The first one was to get the initial idea of the importance of RCT study design, as naturally there were a lot of limitations to the 90s RCT. There will always be limitations to each and every one trial, but the majority of these mistakes can be avoided with good planning. The second teaching issue was that the importance of long-term follow-up and outcomes. As for this RCT, I did the 11 and 15-year follow-up, showing somewhat suboptimal sustainability with fundoplication results at longer term, which of course is crucial information when you think about the initial treatment decision. Dr. Ovaska is already retired, but he was also the reason why I started metabolic bariatric surgery, as one day in 2003, in a very surgical, straightforward Finnish manner, told me that I would start doing metabolic bariatric surgery. There was no question mark at the end. It was really not that prominent in Finland at that time, and I have to confess that initially I was more enthusiastic about the laparoscopic procedures than the whole process. And I was not really that convinced about the idea in general, but as a fan of evidence-based medicine, I did start intensive reading on the available literature, and of course, only to realize that why on earth haven't we been doing this already for the past 2 decades, or at least the last decade. At that time, I could really not understand how interesting and rewarding this command has been on my career, as it has brought me together with so many brilliant colleagues and surgeon scientists with a big international IFSO family and friends. During these some 20 years, I have seen both the importance and challenges of clinical surgical science and the surgeon scientist actually doing at minimum 2 jobs. During the past 2 decades, however, I think the culture within clinical surgical science has greatly evolved in the right direction. I think the kids in a sandbox actually reflect this nicely, as previously it was like on the left is like, I will not tell you what I'm doing, and I will not let you borrow my bucket, and you play in your own sandbox. But currently we have fortunately realized for most of the time that playing together and collaborating nationally and internationally, and also with multiple subspecialties, creates nothing but great synergy, a clear win-win situation resulting in the most important aim of our research, which of course is the treatment improvement for our patients. Investigator-initiated RCTs are a burdensome entity from start to finish. This is an overarching model modified from the ANSMUS clinical trial network in Australia and New Zealand, it nicely portrays that as first, you need to have a good research question. And in clinical surgical science, you need to be a surgeon scientist to actually be able to ask the right question. Then comes the next crucial part of planning your study, as if you make errors at this phase, you're already shooting yourself in the leg even before you get started. For this part, you need to have a biostatistician and someone really familiar with RCT methodology. You also have to adhere to real life. The trial needs to be planned in a way that you're able to enroll the patients and conduct and complete the trial within reasonable time, or otherwise your study hypothesis actually may be already obsolete, or you will never even finish your trial. The third phase of conducting the trial actually usually needs funding, but even though I have to say that most of my RCTs actually did not have funding prior to starting them, so enthusiasm always, that helps. Part 4 of disseminating the results is, I think, maybe the easiest part, and of course, choosing the right target forum for the right audience is of course important, but this is especially important for the 5th phase of implementing the results. It sounds much easier than it actually is, and I will get back to the implementation issues a bit later in my presentation. But to keep us humble, it is evaluated to take approximately a median of 17 years for a trial result to be implemented in clinical practice. And this really is something that requires a lot of work, and it will not happen automatically. In real life, and I know all the trialists in the audience can relate to this, actually doing an RCT from start to finish most often feels like a hurdle after a hurdle and then a brick wall and then the same thing all over again. It is kind of like the Amazing Race, with its U-turns, roadblocks, detours until you reach a destination, and then hopefully you are going to hop on the pit stop floor mat, hopefully to hear that you are the first to arrive, or at least that you won't be eliminated. I will just quickly show you the work we did in 2022 for JAMA Surgery. So this is their series of Guide to Statistics and Methods. So a 10-piece series of short papers on all aspects of RCTs, from design to permissions through conducting the trial and publication of the results. So that's freely available to everybody. Despite the challenges that we have, we do need to pursue the highest quality possible surgical science in RCTs, but also in other high-quality study designs, such as large prospective registry and observational cohorts. RCTs will always have the inherent bias of representing a kind of a selected optimal patient population in an optimal expert center. So having, for example, a good registry cohort study on the same outcomes will markedly contribute to the generalizability of the RCT results, and both of these are, of course, needed. I would really like to encourage all, and especially the high-volume centers, to conduct prospective cohort studies. It would be so beneficial and not nearly as arduous as conducting an RCT to prospectively collect their data thoroughly and also aim for a feasible long-term follow-up. I think a great example of this is a recent paper in the BGS by the Genoa group, by Professor Papadia, based on the work of Nicolas Copinaro, and they presented their 20 and 30-year results of BPDDS, but I will come back to this a bit later in my presentation. Sometimes these previously described challenges are further complicated by the fact that the new research question actually contradicts the current clinical practice, which really may just be eminence-based medicine, not evidence-based. And some of the current clinical practices actually have not undergone robust scientific assessment. Changing a treatment paradigm is always very difficult, and it takes time. But sometimes the poetic idea of taking the road less traveled by is needed, as it may take major, it may make major, but if not all, the difference. With this introduction to the challenging treatment paradigms, I will have to shortly deviate from metabolic bariatric surgery to quickly show you my other main research interest, which is acute appendicitis outside the field of metabolic bariatric surgery. SLEEVEPASS was my first RCT as a PI, but it was quickly followed by my APAC study group RCTs. I think acute appendicitis is a great example of eminence-based treatment paradigm, as for over 130 years it was thought that acute appendicitis always progresses to perforation, which we know is not true. We know that there are two different diseases, uncomplicated and complicated acute appendicitis, and by saying we know, it means that we have data. We have evidence from clinical and epidemiological studies and differences in microbiology showing that we have two different diseases. And the diagnostics and treatment options actually should be based moving away from the yes-no diagnostics for acute appendicitis towards defining appendicitis severity. Here you see very shortly the APAC research continuum, so it's like doing more RCTs actually ends up in more questions. So the one on the top is the current one we just initiated a few months ago. It took us 2.5 years to get that started. It's important to understand that all of these trials assess the patients with uncomplicated acute appendicitis. So this is not for all appendicitis patients, but of course applies to the majority. The first APAC trial on the bottom actually showed that the majority, antibiotics alone was a successful and feasible treatment for the majority of patients without any increased complications. APAC number 2 showed that oral antibiotics were sufficient, enabling, of course, outpatient treatment in the future. APAC number 3 was a pilot RCT showing that perhaps even antibiotics were not needed, so a placebo-controlled double-blind study. We aim to confirm now both the role of antibiotics and the need for hospitalization in the treatment of uncomplicated acute appendicitis by conducting the current APAC number 4 trial, which is a double-blind non-inferiority multi-center RCT comparing PO antibiotics with PO placebo in an outpatient setting. I know this research is really not the popularity trick among surgeons, but do not be alarmed, as we will still be doing appendectomies. We will just focus them much better. However, most likely at minimum, we can actually perhaps avoid about 50% of the current appendectomies. And as the pie of resources really is more or less fixed all over the world, we really need to use the resources in the best and most cost-beneficial way. The saved OR resources from appendectomies, I think, could be used for something else much more beneficial. And I, of course, may be somewhat biased here, but a great example would be metabolic bariatric surgery. This outside-the-box line of thinking, I think, truly applies to, or one could even say that it's defined by the pioneers of metabolic bariatric surgery, as Dr. Mason realized that the procedure he was initially doing was not working what he initially thought it would work for, and then he looked at this from very other perspective of making the weight loss a desirable effect, and the rest is history in the treatment of severe obesity. I cannot even imagine the resistance and controversy these pioneers in our field received for creating this whole new field of surgery. And I really enjoyed listening to the 2021 Mason lecture where Dr. Jaime Pons presented the colleagues, Dr. Mason, Dr. Scopinaro, and Dr. Sugarman, rightly as the three pillars of metabolic bariatric surgery. I will now move on to the story of the SLEEVEPASS trial and the necessity of having sufficient long-term follow-up results, especially in our field of treating the chronic disease of severe obesity, after hopefully giving you somewhat a realistic picture of both the importance and challenges of high-quality research. As I told you earlier, SLEEVEPASS was my first ever RCT, and at retrospect, there are of course so many things I would do differently, but all in all, I'm happy how it has been able to contribute in the much needed long-term data. Where it all started from, we have to go back to the eastern part of Finland, a city called Kuopio, and a hotel bar there. But before that story, I need to introduce a Finnish pioneer for metabolic bariatric surgery, a very tall guy in the background, Dr. Mikael Viktorsson, who's a very good friend of mine, but sadly passed away in 2018. He was fortunately under the influence of Swedish colleagues and friends to understand the evidence-based nature of metabolic bariatric surgery already early on. So he really would have thoroughly enjoyed to see the progress, and I'm sure he would have wanted to be here today. For the bar question, I don't need a raise of hands, but I think some of the colleagues in the audience may be able to relate to the question of thinking about the number of great ideas that you've had after 1 a.m. I think for me, the number may be somewhat limited, but I have to say that the SLEEVEPASS trial still makes it to the top 5 best ideas after 1 a.m. Because at the hotel lobby bar counter, Mikael and I drew the SLEEVEPASS study flowchart and with additional notes actually on a paper napkin. And then a year later, we started enrolling patients. But I do have to confess that that is a fake picture, because the original napkin, which I had for a long time, but it was unfortunately destroyed at a big hospital fire we had in 2014 in Turku. Nobody fortunately got hurt, but the picture also shows the unexpected challenges of running an RCT, because my RCT papers for the initial APAC trial, and they were actual papers at that time, were rescued from the ruins, and you can see that on the right side. So it also shows that we initially named the trial SLEEVEPASS, but then we said it out loud and realized that we need to change the acronym. So whenever you come up with an acronym, please make sure it rolls off the tongue. And as inpatient surgeons, we also initially had stated for the primary outcome to be assessed at 1 year, but we of course soon realized that that's idiotic and this needed to be revised up to 5 years. So fortunately, both the name of the trial and the primary endpoint were amended prior to any publications. We all know the current status of the prevalence of various procedures, with sleeve gastrectomy being the most common procedure worldwide since 2014. Here you also see the recruitment period of the SLEEVEPASS trial, when the trial started enrolling patients in April 2008 up to June 2010. The prevalence of sleeve gastrectomy globally was very low, but during the enrollment period, it had a very steep rise. I've often been asked that whether I had like a crystal ball kind of vision that this was going to happen, but it really was not the case. Based on the seemingly more simplified surgical technique, and even more the potential long-term benefits of having an intact GI tract, made the procedure very interesting in our minds. With my recent PhD spark enthusiasm for clinical trials. I was just waiting for such an idea, and as the opportunity presented itself, I wanted to push for an RCT just out of pure clinical interest and in this relevant study question. It needs to be noted that the peak popularity of sleeve gastrectomy came way before any long-term data on the outcomes was available, as our RCT 5-year results were published along with the SLEEVEPASS trial 5-year results in 2018, and the 10-year outcomes only 2 years ago in 2022. This slide mainly portrays how we all have our biases. When the initial report came out in JAMA for the 5-year result, it was all of the pro-sleeve colleagues were saying that this is great. You now showed that sleeve is as good as bypass, and then the exact opposite for the pro-bypass colleagues, and they were looking, of course, at the same paper. So when reading the literature, I think it's really, we need to aim to have an open mind, recognize potential own biases, and actually just look at the numbers and the results. I wanted to show you the importance of international collaboration, as since 2017, we have been working very closely with Professor Ralph Peterle from Switzerland, who is the PI of the SLEEVEPASS trial. Without actually knowing of each other at the time, we ended up designing 2 very similar trials with similar endpoints. They got started in Switzerland a bit earlier, but we were much faster to recruit and finished enrollment a bit earlier. So ours was an equivalence trial, and the SLEEVEPASS more of a comparative trial. So here you see the trial characteristics and our pre-specified equivalence margins, which have haunted me ever since. Neither one, when you look at the results of the separate trials, had a difference between the 2 procedures, even though weight loss was a bit better after one-wide gastric bypass. But based on the initial study designs, in our study, the difference did not meet the pre-specified equivalence margins, and in Ralph's trial, there was no difference after adjusting for multiple comparisons. We then decided to join forces and merge the data on an individual patient level, as with this merged data, we did not have to adhere to the original study designs. This is a very recent picture from the IFSO EC meeting this May in Vienna, organized by our current IFSO president, Professor Gerhard Prager. And in this meeting, we literally joined our forces and had a joint presentation on the 10-year data. The merged data with a superiority approach and a larger patient cohort actually showed a statistically significant difference between the weight loss, even though both procedures showed good and sustainable weight loss at long-term follow-up. I think another very good example of the study designs and effect of the number of the patients, I wanted to show you the very recently published Dutch sleeve bypass trial with a good follow-up rate at 5 years and 642 patients. I was presenting this yesterday, but I just wanted to again show you the idea that actually they had a difference that was statistically significant, but you always have to look at when you have a high number of patients. The p-values don't really tell the story, so you need to look at the actual difference between the 2 groups, because statistical significance is very different from a clinical significance, so this has to be noted. Their conclusion was that sleeve gastrectomy and one-wide gastric bypass had clinically comparable excess BMI loss according to the predefined definition for equivalence. However, one-wide gastric bypass was associated with higher total weight loss and significant advantages in dyslipidemia and GERD, but they yet had a higher rate for minor complications in one-wide gastric bypass. No difference in major complications, other comorbidities, or overall health-related quality of life, so very consistent results with our SLEEVEPASS and SLEEVEPASS trial. For the merged data, we dug a bit deeper to look at try to obtain the previously unpublished type 2 diabetes duration, as the trial themselves had very different remission results, which was explained by the difference in the preoperative duration. And of course, naturally, the longer the duration, the poorer the remission. It has to be noted that both trials separately and even with the merged data, they are underpowered to detect differences in type 2 diabetes remission, and this is why we need international collaboration of all RCTs that have surgical groups comparing sleeve gastrectomy with Roux-en-Y gastric bypass. And I'm very happy to say that this idea of an individual patient data meta-analysis, so an IPDMA, has been well accepted by all PIs, and we're looking forward to doing this after we have the sufficient number of patients reaching the 5-year time point data. Then moving on to the importance and challenges of long-term follow-up. I know we are very fortunate to have a very good follow-up rate for both overall follow-up of 85% at 10 years, and 78% of our patients in our SLEEVEPASS trial underwent gastroscopy at 10 years. This really, I fully get it, it's much harder here in the States. It's much easier within our communal healthcare system and a smaller country, and we have really, the patients are really prone to support scientific research. But again, this was my PhDs and my research nurses actually calling them and begging them to come in. So really, it's not easy even for us. I think GERD is another part of the SLEEVEPASS trial story, because at the time of the study initiation, nobody knew, or at least we didn't realize, that GERD could actually be such a major issue after sleeve gastrectomy. So during the study follow-up period, there were alarming reports of high de novo Barrett's esophagus after sleeve gastrectomy, up to the prevalence of 14 or 17%. And we thus decided to do this amendment to the study protocol of doing an upper gastrointestinal endoscopy for all patients at 10 years, and we will again do it at 20 years. At the study initiation, we unfortunately did not have any standardized assessment of GERD, even though we had severe GERD and large hiatal hernia, and that's quotation marks because, of course, that is way too vague. I think with the definitional issue of Barrett's esophagus, I think this nicely gets me to the last part of my presentation, assessing the need for standardized outcomes, as the difference, I think, between the papers may be related to the definition of Barrett's esophagus in addition to potential sampling differences, and I think that's most likely the reason explaining the different prevalences. So we were using, of course, the US definition that you have to have intestinal metaplasia, and the similar result of much lower Barrett's esophagus was also found in the SMBOSS trial at 7 years. And remember, you need to also have the endoscopy and also the confirmed histopathology, so both are required. So we did have much more esophagitis, much more GERD symptoms, but no difference in Barrett's esophagus, and much lower rate than previously reported. So I don't really see Barrett's as being the issue for sleeve gastrectomy, but GERD definitely is, and that has to be taken into account in our patient selection. The final part of my talk is focusing on the importance of having standardized and truly compared outcomes between different studies, which requires that we actually use these definitions in order to prevent from us to compare apples and oranges. For the definitions, I do have to acknowledge the hard work I think IFSO has been doing to take this important issue forward. And this is the IFSO consensus from last year with a large group of experts, partially focusing on the correct terminology and reporting standards, published in the Obesity Surgery earlier this year. I don't think the terminology work would have been possible without Dr. Lee Kaplan, as he was instrumental, I think, in this model, and Gerhard and I had the pleasure of contributing to this section. Some of the statements are self-evident, which they seem to be self-evident, but unfortunately they're not, as we're still using stigmatizing language. And I think these are the two terms that I wanted to show here. So no more non-responders, and of course nobody has said failure for the past 5 years, but the chosen term was suboptimal initial response and afterwards recurrent weight gain. So please remember that. This great work by IFSO was continued this year in May in Vienna by Professors Prager, Cohen, and Busetto, with another consensus on obesity management medications with vast representation from medical field, as the terminology, of course, cannot be restricted to surgery itself. So we need to talk the same language. So obesity management medications. I wanted to show that ASMBS also aimed to really work towards the same important goal by publishing the standardized reporting outcomes in 2015. I think this is a very interesting study that the Dutch colleagues did on the implementation of these guidelines. And as you can see by the numbers of use, the implementation was almost non-existent during the follow-up period of 5 years. So this was addressed in an editorial by Drs. De Maria and Altieri, stating that the challenge of implementation, publication of the guideline or a consensus result, of course, is not enough. We need to implement it within the daily practice, the way we use it within research and within the societies, and of course the scientific journals need to adhere to the current agreed terminology. Based on our 5-year emerged data, we decided to work on a composite endpoint outcome score to enhance the comparability of different studies. The logo, of course, is always of great importance, and we started there. So that was the first thing we had. And also the acronym that, again, would easily roll off the tongue. We published the SF-Barry score just recently in JAMA Surgery, and the score is freely available on the website, and you can see the QR code. And the website actually has all the tools you need to collect your data and use the SF-Barry score. The idea of a composite endpoint is that we wanted to have something that's simple and feasible in real-life practice, and we wanted to avoid categorical variables and have a composite endpoint, essential outcomes, and also, for the implementation reasons, data that we actually have. So the data that we chose for that is stuff that you actually need to have. So we had the clinical evaluation, our clinically orientated biostatistician working on the fact that we got the score created. There would be, of course, so many more outcomes and parameters of interest, but for the sake of implementation and actual use, these are the outcomes all centers need to have if they're doing metabolic bariatric surgery. So you need to have weight loss, these 4 comorbidities, and complications. Not to say that quality of life is not of importance, it is really a major outcome, but really even in our RCTs that have a very good long-term follow-up data, we only had the quality of life data for 70% of the patients. So in real-life practice, I don't think we can have a score that would be mandatory to have the quality of life in. The idea was to markedly improve the very good initial idea of the Barrow score, which actually has not been very widely used, even though it was already available in 1998. So really, this was the idea. This is just to show that I think one of the problems with the Barrow score is that you actually can interpret the score in a very different way. So we wanted to avoid this, and we have very clear instructions on how you calculate the score. So there's no room for interpretation. And this is the range of the Barry score, and here you see the distribution. So on the upper left side corner, it is very evenly distributed throughout the patient population, and on the right hand corner you see the correlation with percent total weight loss, which is the driving force of all other positive outcomes, so that's weighed twice in the score. You see the difference between the Barrow score, which is on the left hand corner, so a very different alignment for percent total weight loss. This shows the categorization of the outcomes based on the SF-Barry score, and these were based on the 5, 25, 75, and 95 percentiles at 5 years. Similarly to the ASMBS standardized outcomes, publication of this SF-Barry score is just the beginning, and the next step, of course, is to validate the score in large registries to see whether it works in real-life data, as RCTs are limited for the generalizability. This is our SF-Barry score group working hard actually at IFSO Madrid, and in the picture with me are Professor Ralph Peterle and Professor Marco Bucher, both from Switzerland. For the generalizability, the merged data was already a small step forward, as the baseline characteristics of these 2 trials were very different. The Finnish patients ended up being much older, sicker, with a significantly longer preoperative type 2 diabetes duration. This is going to be the only unpublished data I will quickly show you today, as we have just gotten the preliminary results of this validation in the Nordic registry. So This is part of the validation group only just last week in Turku at our Nordic Baltic Bariatric Surgery meeting, and the validation data has been analyzed by our biostatistician and our Dutch PhD student Floris Bruinsma, who is in the back beside Simon Niehues, and from the Netherlands Ronald Leem on the right, and Johan Ottosson, who is probably here also today, on the left side from the SOREG registry. So differences, we have over 21,000 patients in all of these 3 registries, and there were some differences in the baseline characteristics between these different registries. So the Dutch registry had significantly less male patients. There were much more the prevalence of sleeve gastrectomy, which was much higher in the Norwegian data. And the Dutch patients actually had significantly less comorbidities compared to the Swedish ones. For the differences in baseline compared with the merged registry data and the merged RCTs, so the merged registries versus the RCTs, there were more male patients in the RCTs, and the BMI was 46 versus 42.3. And there were actually twice as many comorbidities in our RCTs. The patients were much sicker. So this actually adds to the generalizability because it is much better, of course, for the score to work in different baseline population. It is normally distributed in all of the registries. Correlation with percentile weight loss was very similar despite these different baseline demographics. And the mean score between the registries and the RCTs was actually very similar, and also the distribution for the categorization. So this is the website. Really happy if you check it out. These actually 2 slides I received from Ricardo Cohen and his excellent presentation yesterday on the importance of RCTs within our field. So when would RCTs not be necessary? And I think this is really nicely demonstrated by the algorithm Ricardo showed yesterday. So if you are actually assessing a new principle, you definitely need to have an RCT. If you're not, that's not necessary. But if you're claiming superiority of effectiveness, you definitely need to go back to the RCT road. If you are saying that there is no superiority claim, but are you changing something significant, are a new indication for a certain population, you again need to go back to the RCT path. The only thing when you can stay on that path is if you say no to all of these questions. So actually the answer is nearly never. They're almost always necessary. So thank you for the slides. So even though RCTs are burdensome to complete and have this hurdle brick wall effect, we should aim for conducting RCTs as their basis for the changes in treatment paradigms. That said, I think it's also extremely important to have prospective observational cohorts with actual long-term follow-up as demonstrated by the Papadia paper on BPDDS long-term outcomes that I showed you before. They had a very good 20-year follow-up and a very limited one for 30 years, but that is still the best evidence we have on this, as there are no other similar reports available. So there were major nutritional and malabsorptive complications at long-term follow-up as demonstrated here, and I urge you to check the paper out. As more hypoabsorptive procedures are gaining popularity, the importance of long-term follow-up, I think, is highlighted because if we operate on a 30-year-old patient, they will have the same operation at 50 years and at 60 years. This is something we aim to underline in this associated editorial with Drs. Cohen, Schauer, and Rubino. Papadia et al. Reminded us that operations should actually be judged for their long-term effects, and that novel procedures should really be compared with well-tested standard operations like Roux-en-Y gastric bypass before they are used in routine clinical practice. Comparison to the gold standard, this is the ChatGPT version of gold standard in bariatric surgery on the left. I put in that in ChatGPT 4.0, and that's what they came up with. So of course, it is always a trade-off. You gain something, you then again have to give something up, but this is the thing that we actually have to consider for our patients. To conclude, I would really like to encourage all of you to do clinical research and follow up on your patients, and if not within an RCT, then within the registries that you've been doing a great job here in the US, and also large volume centers for the prospective cohort studies. I asked ChatGPT for an image to demonstrate combining surgery with clinical research, and this is what they came up with. I'm not really sure what they're operating on the picture on the right. As you need to see a surgeon scientist to become one, I also asked ChatGPT how a surgeon scientist look like. We still have some diversity and inclusion work to do because ChatGPT automatically puts a handsome male surgeon if you type in surgeon. So I then added the word female into the request, so female surgeon scientist, and this is what it came out with. I have to say that she looks very determined. The role of national and international collaboration is critical, and there is immense synergy in working together. This also, I think, applies really in the medical field within the treatment of severe obesity with OMMs, as we are working towards the same goal, and it will be very beneficial to initiate more RCTs on the adjuvant use of OMMs, paving the way for a more tailored treatment. I really wish to thank my Swiss collaborators, my SLEEVEPASS study group. This is our most recent PhD. And I also have to thank my family, my husband Ari and my 2 kids, Rosa and Franz, for enduring me being a surgeon scientist and for their support. I also wish to thank my dear friends Marina and Rachel and the ASMBS for this awesome opportunity to speak here today. And I will conclude my talk in the quote by the economist and data researcher Deming that I think kind of says it all. Without data, you're just another person with an opinion. Thank you very much for your attention.
Hold on. Yes. So this is our Mason lecture plaque. This is for you.